Thanks, Jeremy. I'm not sure if you see what I see, which is a presenter view, or do you just see the screen? I'm not quite sure.
We can see it perfectly. It looks great from our side. Okay,
fine. So just unfortunately, I'm in Parkview, Parktown, and the substation has just blown up. So I'm having to. I don't have an internet connection. I'm having to use a phone connection. So if there are any problems, my apologies. So I'm going to talk about schistosomiasis control, largely from the public health perspective rather than from the individual patient perspective, although we will look at both as we go through. I'm going to start with a case or some cases. So this is 4 children sitting down having lunch at a rural school. The 2 in the middle are mine, and the 2 on the outside are their friends. But this is a fairly typical occurrence in a rural area in the Eastern Cape. This is where they live. This isn't absolutely typical. This is my house, and it's a little bit atypical because it's got a car and it's got quite a few solar panels. But most of the children in the area live in something similar to this. There is actually an outside toilet here, and until a few years ago, most houses didn't have outside toilets or toilets of any kind, in fact, and they just used the bush as their toilet. But actually, in recent years, there has been an increase in toilet facilities in the area, which is likely to improve health outcomes. But this is sort of largely where the children live. This is my 2 again. This is the kind of body of water you might expect people to play in. This is actually in KZN, but it illustrates the purpose. A still body of water, fresh water, where children might be expected to play, women might be expected to wash. Typically, women in these areas. And so the question is, if a typical child, not my child, who I didn't allow in that water, but a typical child turns up to the clinic and they have this, their urine, their mother says, let's take a case, let's say an 8-year-old boy comes into your clinic in a rural Eastern Cape or rural KZN area, and the mother says the urine is red and you dipstick in it and it's blood. The question is, what is the differential diagnosis? I'll go first. Schistosomiasis hematobium as number 1. Would anyone like to? I'm obviously not a pediatrician, but I know we have pediatricians on the call. Anybody who's a pediatrician like to give us a differential for this finding?
Tom, you break up a little bit, but I think we got the most of it. Is the picture for us? Is it with the huts in the Eastern Cape?
I don't see the note. If anyone's typing, I don't actually see the note. See that?
Okay. So, what do people think is the cause? Type in the chat.
Okay, so I just went to the chat. Sorry.
Oh, I think we've lost Tom, who should be excitingly joining us thanks to a broken power station. PSGN, Nasisa. Post-streptococcal glomerulonephritis, I think that means. Tom, when you are here, you're welcome to restart your video. What do other people think in terms of hematuria on a dipstick? Oh, we've got UTI, IgA nephropathy. Oh, another IgA nephropathy coming through. Okay, let's see if we can track down Tom again. Trauma, I like. Let's see.
Sorry, I think I was muted. I've moved to try and get a better signal. I was muted. Sorry about that.
That sounds good. Tom, we can hear you nicely. We don't see a signal yet. And while you're with that, I can tell you what the chat's been saying so far. So there's hematuria, there's post-streptococcal glomerulonephritis, UTI, a couple of votes for IgA nephropathy, trauma, kidney stones. Yeah, those are the differential that's given so far.
I think that's probably correct. I think in this setting, the vast majority of cases are schistosomiasis hematobium, and there isn't much left. But the most likely second diagnosis is post-strep GN. In a symptomatic child, then UTI. I didn't say the child was asymptomatic. Similarly, I think kidney stone, maybe a bladder stone would be possible, I think. But I raised the, just checking you can hear me now. I've moved to a different state. Can you hear me?
Yeah, it's looking great. We've got the you just hit slideshow mode when you're ready. Yeah.
Oh, slideshow mode. Yeah, got you.
Yeah, that looks perfect. Yeah.
Okay. Okay, now we're moving. Okay, so just to get you in the mood, and so that this isn't a completely didactic talk, I just wanted to get people thinking about what that might be, and clearly the differential will be different in different places. Now, you can't come to a talk on schistosomiasis without seeing a life cycle, I'm afraid. So I will take you through that in a minute, but I just want to give you some of the background on schistosomiasis as a world, as a disease in the world. It actually ranks second as a global cause of death from a parasitic disease. Only malaria of parasites causes more deaths, and it's thought to be close to 300,000 deaths per year, typically in adults from long-term complications. But more so than mortality, it's really a disease of morbidity. And it thought to cause up to 70 million DALYs to be lost annually. That's disability adjusted life years. That's similar to the DALYs lost to HIV/AIDS and higher than those of both malaria and tuberculosis. So this isn't marked by mortality. It's not always as obvious. And a lot of the morbidity is also not that obvious, which might be one of the reasons why we're not doing so well at eradicating it. Let's just move on to the epidemiology. And this slide, so in 2017, schistosomiasis became a Category 2 notifiable medical condition in South Africa. And Lethlo Chandu from NICD has sent me a couple of slides, and these are the notified cases from 2017 to 2021. Notified case, first, the patient has to seek healthcare. Healthcare has to be available. The person needs to consider this as the differential diagnosis, send the specimen. Specimen has to get to the lab and has to be positive and get back to the healthcare worker, and the healthcare worker has to report it. So a lot of things have to happen for a case to become a notified case. Even so, you can see this is not a very good way of determining the absolute prevalence or incidence, but it gives you an idea of the distribution in KZN, Limpopo, and Mpumalanga, and in the Eastern Cape. This is from Liesl Deboni from PLOS NCD, just from last year. And this is, rather than notified cases, this is laboratory confirmed cases. So similar things have to happen in terms of health seeking behavior and sending tests. And you can see that I think this is a good illustration of where schistosomiasis is in South Africa. Just to say, this is almost exclusively hematobium. And it's like from about midway up the coast of the Eastern Cape, up into KZN, Mpumalanga, Limpopo. And I think it's reasonable to say that wherever there's a yellow dot, there's likely to be ongoing transmission in the community, and the black dots largely are going to be imported cases, because people will always move. Again, from Liesel's paper, these are trends in tests and their estimated prevalence. The estimated prevalence might be coming down fractionally, but it's a little difficult calculation to make from lab tests. The amount of tests being done has gone up quite a lot from 2011 to 2018. And this is the age and gender distribution. This is again from Leflow from the notified cases, and you can see very clearly that the peak is in the early teenage years, 10 to 14, not so much in under 5s, interestingly, and then that drops off into adulthood. And you can also see quite clearly that there's a gender disparity, with far more, particularly in where the prevalence is highest, that there's a much higher incidence in boys than girls. I'm going to ask you why you think that is in a minute. But first, I'm just going to go back to the life cycle, which I did say I would go through with you briefly. So we're largely talking, I'm going to start with the eggs at the bottom. Okay, this is the life cycle for 4 species of Schistosomiasis. You can see them there: Mansonia, Japonicum, Mekongi, and Hematobium. We're going to largely talk about Hematobium. There is a little bit of Mansonia in South Africa, largely right up on the border with Mozambique, but probably makes up less than 5%. And in most areas where there is Schisto, there is 0 Mansonia. So we're going to focus on urinary Schistosomiasis, which is Hematobium. So we'll start with the egg. The egg gets into the water, which hatches into a myristidium. The myristidium penetrates the snail, and there's 3 different snails for the essentially 3 different species. If you do cert ID SA, you may find that some slightly deranged person asks you to remember the names of these snails. I would advise you not to bother. That's not going to help you at all looking after patients. But there are 3 different snails for 3 different species. The parasite develops in the snail and then comes out as a sporocyst, which develops into this free swimming Cercaria, which has got this forked tail. And then the person, to carry on the cycle, has to get into the water, has to get this fresh. This is, just to be clear, these snails are freshwater snails. They don't live in the sea, the salt or brackish water. So this is fresh water. Person is exposed to the water, usually by swimming or bathing. This Cercaria burrows through the skin and loses its tail. And then this bit's always not covered very clearly in life cycles, but somehow it gets from the venous system, it must go through the lungs. This is far too big to go through a pulmonary capillary, so it's not really well described to me exactly what happens in the lung. It must somehow get lodged in the lung and get into the pulmonary arterial system. And then again, it's sort of skipped over, but ultimately it seems to end up in the portal vein, where these develop into adult worms. And these are a male and a female worm intertwined. This is a mating pair. And these mating pairs then navigate somehow to different venous plexuses. So the one we're talking about here is the venous plexus of the bladder, which, as we'll come to later, is also related to the cervix. And then these eggs that are produced by these mating pairs are shed in the urine. In the other species, it's largely that they go to the bowel and the rectum, and the eggs are largely shed in stool. So to complete the cycle, the person has to urinate or defecate into the fresh water, which is where the eggs are, and that completes the cycle. So I'm going to ask, if I may, what people think, why people think more young men than young women are infected with Schistosomiasis hematobium.
Okay, so we'll give a second for people to type or raise their hand if they want to call out. One suggestion in the chat, Tom, I'll just go through them. So one is they swim more.
I can actually see them. Yeah.
Oh, you can see
they swim more. Behavior. Okay, it's a little, yes, it's a they have more exposure. Okay, boys are more likely to swim in rivers. Okay, they are naughty. Us boys like to swim in rivers and dodgy puddles. Boys can see their urine as they pass and are more likely to present to care. Good point, Jennifer Hughes. Bionfilaria sticks in the brain from first year. Okay, that's the name of Andy Gray's giving us the name of the snail, which I'm sure is correct. So I don't know the exact answer, but I think the answer is exposure. And for anyone who's lived in these parts of the world, I'm sure there are people on this call who've lived a lot longer than I have. I've spent some time. Boys go out to play and girls stay in and help their mothers, which is a terrible state of affairs, but that has been my experience. So largely there are troops of boys playing around in the fields, playing in the water, playing at this, playing at that, and the girls are much less likely to be allowed to go out and play with them. So it's a terrible indictment, I think, and I think that's most likely the reason. Unfortunately, although the only silver lining, if you can say that, is that the girls are less likely to get schistosomiasis. Okay, so so that's given you some idea of the relative prevalence and the age distribution and the gender distribution. But what about the absolute prevalence? That's obviously very difficult to get a denominator from some lab data. So I'm just going to present one study. This is a study that I did with some colleagues about a year ago in the deep rural Eastern Cape, an area actually quite near the coast, and such that much of the swimming that I witnessed, including my own children, was in saltwater. And you did actually get the feeling doing this that the kids that live very close to the sea and to the saltwater estuaries were less likely to be infected, though we were never able to do any geomapping or anything. So what we did was we went into about 4 schools. We lined up all the children, class 1, class after the other, gave them urine containers, asked them to produce some urine, and then we got standard urine dipsticks, cut them in half down the middle, lengthways obviously, so that we could get more out of them. And we dipstick the urine for blood, and any that were positive we treated with praziquantel, and we excluded menstruating girls from this study. What we found we looked at 535 kids, mean age of about 12, and slightly more boys than girls, but 47% girls, and we found hematuria in 42% of these children, and with the same prevalence distribution that we saw before, 54% of the boys and 27% of the girls. And if I showed you the age disaggregated by gender, you'd see the same thing. Unfortunately, this is yet to be published. I'm still waiting on my colleagues to get the right approvals to publish this, but this would be the largest survey in that part of the Eastern Cape. I won't show you all the other prevalence surveys, but there are many up the coast, particularly in KZN, up into Limpopo and Mpumalanga, and they largely show the same thing, that hematuria is present in approximately 40 plus or minus percent of kids in secondary school age. You can see it drops off under 12, under 8, and that's also the experience, and that presumably that's also due to exposure, less exposure in younger kids. So that's the epidemiology. That's how much schisto we have in the country. What about the effects? So what does it actually mean? I mentioned that it's more a disease of morbidity than mortality, and that's certainly true in children, which is what we're discussing now. This is a slide from Anna, who works at London School, one of her papers. And actually in this paper, this includes dosing with praziquantel, which is something we'll come on to. But it's a sort of schematic showing what can happen. So actually, this is suggesting that children only become exposed in their preschool, which may be true, but actually it's possible for a child to be bathed in contaminated water for their first bath of their life and become infected as a neonate. That's actually possible. But we do tend to only see the prevalence picking up as children get beyond the preschool era, preschool time. And what does it do? Well, clearly there's a continuous loss of blood in the urine for these patients, but there's also a pro-inflammatory state within the body, which is debilitating. And so this loss of blood can be a potentiating factor in stunting and anemia, but it can also be the pro-inflammatory state, probably more than just the anemia itself, although these things are all linked, are clearly linked to decreased cognition and poor school performance. Now, if treatment is given, as it is in some places, and we'll come to that just now, then it is possible to reverse that with a degree of catch-up growth and improvement in school performance. Also, there's the issue of both male and female genital schistosomiasis, which I'll come to in the next slide. So if children make it through adulthood despite these problems, or become infected later in life, then the more chronic comorbidities are things that we learn more about, certainly in adult infectious diseases, which are liver fibrosis, typically causing histologically pipe stem fibrosis with relatively normal liver function tests, but with portal hypertension, splenomegaly, and hypersplenism. Clearly anemia can and pro-inflammatory states can also be part of that, leading to decreased productivity, but also impaired reproductive health and things like genital stricture, urethral strictures. Worth note on its own is female genital schistosomiasis. And I don't know if Erin is listening. I can't see everyone on here. Erin Kretland is really the doyen of this condition, has worked very hard on it. This is a picture of a cervix with so-called sandy patches, which are typical of cervical schistosomiasis. And this is a chronic condition causing itch, discharge, bleeding, dyspareunia, can lead to infertility, and importantly in the areas we're talking about is an independent risk factor for HIV acquisition, which you can imagine looking at the inflamed nature of that cervix. So it's not uncommon for a woman to have chronic vaginal discharge, for this to be assumed to be an STI, for her to have multiple treatments which are ineffective, and then to be, you know how clinics often are, perhaps to be castigated that they've not been using condoms and they're getting reinfected, when all along their problem was actually cervical schistosomiasis. So this it's a very important topic and an important part of the differential in a woman with the right exposure history and any of these symptoms. So if those are the side effects, what about, I'm going to move slightly to talk about diagnosis, and this is really moving more into the individual than the group, but those of you who've heard me speak in this forum before know that I'm slightly obsessed with how we make diagnoses, so you'll forgive me for delving into that here. But if you want to make the diagnosis of schistosomiasis in an individual, then as with any diagnosis, you need to, if you have a test available, and we're going to talk about the tests that are available, you need to be able to develop a pretest probability. Clearly, you need to have an exposure. Someone who's never been exposed to fresh water in a area that has snails is not going to have schistosomiasis. So a clear history of exposure, that could be in a traveler. If somebody tells you they've just spent a week swimming in Lake Malawi, then they've clearly got a high exposure level, but that's also part of the history. There are also some surrogate markers that may help you, such as eosinophilia due to the migratory worms. In an older person, perhaps portal hypertension with relatively preserved liver function tests may all allow you to come up with some reasonably accurate pretest probability. Once you know the pretest probability, the other thing you need to know is the treatment threshold. So that's the probability at which, if you don't have any more tests, this is when you've exhausted all your tests, and you're just left with a patient in front of you, and you have to decide whether or not you're going to treat them when you're neither 0% or 100% sure that they have the condition. So that's the treatment threshold is affected by many factors. In this case, you've got, in terms of treatment, you've got a very cheap drug, a very low barrier to adherence because you take it in over a single day or a single dose. The drug has very low side effects. In fact, the side effects are thought to largely be driven by the death of adult worms, a kind of Jarisch-Herxheimer type of reaction. And so typically people who don't have the condition don't tend to get side effects, and only people who you actually treating who have the condition tend to get the side effects, which tend to be they can get fever, nausea, GI upset. But also you don't want the treatment threshold to be too low, because if you just treat every single person as schistosomiasis with low probability, you're going to be missing alternative diagnoses. And particularly in adults, there could be very important causes of hematuria, for example, that you have missed. So this is roughly what it might look like. This is the therapeutic threshold, and I'm suggesting for schistosomiasis it's very low, probably around 5% would be enough. Just to say what happens when you have a test available, and we're going to come to tests. Once you have a test available, you get these two other thresholds. This is the test threshold on the left and the test treatment threshold on the right. The test threshold is below this test threshold. The probability that the person has schistosomiasis is so low that even if the test was positive, you wouldn't be convinced to treat them, essentially. So the probability doesn't get up to the therapeutic threshold, even if it's positive. So these are the people you just shouldn't test because it can't affect your management. In the middle here, you've got patients who you should test and you should act on the result at this rough probability. If it's positive, you treat them, and if it's negative, you exclude the diagnosis. And then on the far right-hand side, you have patients who it's so likely that they've got schistosomiasis that even if the test, you don't need to do the test, because even if it's negative, you're still going to treat them because the probability shifts to the left, but it stays in this range above the therapeutic threshold. So we've thought a little bit about our treatment thresholds and our testing thresholds. We thought a little bit about how we come up with our pretest probability. So what tests are available to us? So there's the circulating cathodic antigen, CCA. There's urine microscopy looking for eggs. There's, as we've talked about, urine dipsticks looking for hematuria. There are serological tests, and there are PCR tests, which we won't go into further. Serology, once positive, tends to stay positive for life. So it's only really useful in someone who's traveled and left the area. So typically a traveler, and if it's negative, it largely excludes the diagnosis. PCR is relatively expensive and not particularly well available, and again would only be used likely in quite high resource settings. So I'm going to talk about the other three tests. So CCA is a pretty attractive looking test in that it's a simple lateral flow test on a sample of urine with a typical control line and test line. So that looks an attractive way to test people for schisto. Urine microscopy, I'm just going to share this with you because it's kind of fun. This is a friend and colleague of mine, a slightly eccentric German doctor who about 12 years ago went into one of the schools near where I was just describing. And he did a similar survey, but just of a smaller number of kids, about 100 kids. He took their urine, he put it in his washing machine at home and spun it around in the washing machine as a centrifuge. And then what he noticed, then he took the deposit and he put it on a microscope slide. And what he noticed was that if he put a couple of dots of this concentrate on the slide, and then he put a couple of cover slips, one each side, and moved them towards the drop, that the urine liquid would get drawn under the cover slide, and then the eggs would get stuck on this edge of the cover slip, which is what this box is. So to enlarge that box, he's like, this is the cover slip here, and these are the eggs sticking against the side. It's a kind of poor man's filtration technique, basically. And if we look on hey, this is a picture that he took. On the left this time is the cover slip, on the right is the microscope side, and these are all the eggs lining up against the side of the cover slip. So this was published. I don't know if anyone's ever taken it up. But if you don't have filtration techniques, which other people would have, this is a possibility. Next is purely dipsticking for hematuria. This picture is obviously macroscopic hematuria, but the vast majority of cases will be microscopic hematuria. So how do these tests perform? Well, there's been some good studies on these tests. Here are two meta-analyses. The top one for dipsticks for hematuria, or for heme, in low prevalence and including low prevalence and previously treated populations. And the bottom one is a Cochrane review. If any of you know some of the giants of the field, like Patrick Boyset and Johannes Rietzmer on this paper, who looked at circulating antigen and urine strips for diagnosing active schistosomiasis. So how do they perform? Well, as with all meta-analyses of diagnostic accuracy studies, they're typically quite wide confidence intervals, but hematuria seems to perform pretty well. In terms of sensitivity and specificity, it's 92% and 97% roughly, which equates to a positive likelihood ratio of 31 and a negative likelihood ratio of 0.8, which we'll just have a look at what that means for an individual patient in the next few slides. CCA, in fact, performs very poorly in hematobium. So you actually have to differentiate whether you're looking for hematobium or Mansenii. CCA for hematobium doesn't appear to perform very well at all, with very low sensitivity and specificity. So don't forget that test, but think of it as a Mansenii test. And microscopy, well, there are very few studies looking at the diagnostic accuracy of microscopy because it's typically used as the reference standard. And so by definition, a reference standard has 100% sensitivity and specificity, even if it actually doesn't, if you see what I mean. But if you have nothing to compare it to, then you're unable to come up with those figures. But typically, taking 3 urines, typically at midday, performing filtration techniques and looking for eggs is typically considered the best reference standard that we have for hematobium. So just using the hematuria dipstick test with these types of figures, just to go back to one of my old favorites, which is the Fagan nomogram, these are the kind of figures you would come up with if you perform that test. Now, we know that the pretest probability is pretty high in these children. So if it was 30%, a positive test would increase the probability to about 94%. That's very high and clearly is going to trigger treatment. A negative test is going to reduce it to about 3 or 4%, and possibly you wouldn't treat a child at that level. However, if you increase the pretest probability a little bit to 50, which is also in the range that we were talking about, a positive test is clearly confirmatory, but a negative test, you're still left with a probability of about 7 or 8% in these kids. So the likelihood is when the pretest probability is this high, that even with the best test you have, assuming you're not able to do 3 lots of microscopy on every kid, you need a cheap, quick test. Even if it's negative, the probability still remains high, and you'd still likely want to treat them. This is just the same slide. Okay, so that was a little bit about diagnosing children, and forgive me for my favorite topic. And that's what you might do with an individual in front of you. What's really much more important really for this discussion is mass drug administration, or public health approach to controlling schistosomiasis. And there are a number of very pretty, very long, very detailed documents about how this might happen. This one is the World Health Organization 2130, ending the neglect to attain the Sustainable Development Goals, a roadmap for neglected tropical diseases, which was published in 2021 and is very long. And it says things like the 2030 roadmap outlines disease-specific and cross-cutting targets and strategies, and represents the voices of the entire NTD community, which undoubtedly it does. And it gives specific targets for schistosomiasis. It's saying that the number was 0 in 2020. The number of countries validated for elimination as a public health problem, which they define as less than 1% proportion of heavy intensity schistosomiasis infections, was 0 in 2020. This is of the 78 countries where schisto is endemic, of course. And the aim is by next year to achieve that in 63% of countries, a couple of years later, 88%, and by the end of this decade, all countries to have achieved that goal, which is ambitious. I think we need to look a little bit more closely at the definition of less than 1% heavy infection. You might well, given that in South Africa it's relatively localized, and where I showed you there are actually large swathes of the country with zero infection. Getting to 1% of the entire population is much more feasible than what is really intended, which is getting to less than 1% in the heavily infested areas, and that map. And that's really what the aim should be. Just a note on the term. The term NTD, neglected tropical diseases, is the one which is typically used. I think personally I find this an unhelpful term. The tropical part, I think it's a very colonial approach. I would much rather these diseases be called neglected diseases of poverty or of low income countries, which is what they are, although largely they are confined to the tropics. As we know, Eastern Cape is not in the tropics. The WHO also have a national NTD master plan, 2021 to 25, and it's full of drawings like this, very pretty, very colorful, explaining exactly what needs to be done with management processes and master plan key components. We even have the South African National Master Plan for the elimination of NTDs, 2019 to 2025. So we're kind of halfway through that so far. And this similarly has lots of very detailed drawings and tables explaining what we need to do. In terms of the actual processes, the WHO has got a very strong guideline on the control and elimination of human schistosomiasis, and I'll just, it's very thorough, gives lots of detail. I'll show you a couple of the key recommendations. That in endemic communities with a prevalence greater than 10%, who recommend preventative chemotherapy as a single dose from all age groups from 2 years of age, and that's yearly, annual preventative therapy. There are other recommendations when it's even a heavier infestation for twice yearly dosing with praziquantel with a coverage of 75%. So that's when infection rates are greater than 10. And there are other recommendations. Recommendation 5, clearly we're interested in if we could break the cycle, for example, any part of the cycle we discussed, if you could remove all the snails, if you could prevent people urinating into water, you'd be able to break the cycle as well as treating, eradicating the worms from people's bodies. And so recommendation 5 is water and sanitation hygiene interventions, environmental interventions, including molluscicides, so chemicals to kill the snails, and behavior change interventions to reduce transmission. I'm not going to focus on the wash interventions, but just to say, I think anyone who deals with this is well aware that one of the reasons that these illnesses don't occur in richer areas is because of improved wash, as well as maybe it's not hospitable to the snails, but if you have good wash facilities, then you're unlikely to get endemic schistosomiasis. So you've seen the master plan. So how are we actually doing in South Africa with controlling schistosomiasis? Should essentially have eliminated it as a public health problem. Well, you can actually go to the WHO NTD tracker, as I did this morning, and you can type in any country you like, and it will tell you how that country is doing in terms of, in this yellowy color, the population that need to be covered by PC, preventative chemotherapy, and in blue bars, the population actually covered, and in red, the percentage. And you can see the top left is total, and that's the same as the bottom right, because that's coverage for soil transmitted helminths. And bottom left is schistosomiasis, and you can see that we're currently sitting at 0% coverage, with around about 4 million people at risk of this. Compare that to Malawi. You can just type in Malawi, you can see that how well they're doing. Their percentage is up to 50% overall. Schistosomiasis around 50%. Similarly, for very high for lymphatic filariasis and soil transmitted helminths. So you can see that South Africa is lagging behind. Has it ever been done before? Well, the answer is yes, it has been done before in this country. When I say it, what I mean is mass drug administration. And so we're talking about not testing individuals with any test, but performing prevalence surveys so that we know where the hotspots are, and we've already shown you that we know this already, and then just treating every child or every adult with praziquantel either once a year or twice a year in a mass program. So has it been done before? Yes, it has. It was done in KwaZulu-Natal. This is published in 2015, but the program they described was actually 1997 to 2000. So over 20 years ago, there was a program, and it was impressive. This is just a snapshot to show that they worked in over 3,000 schools, covering 1.5 million children, and they were able to provide a control program for both soil transmitted helminths and schistosomiasis. But since 2000, to my knowledge, there's been no mass drug administration at all. So what's the problem? Why have we not been able to get these pills into children's mouths and young women's mouths? Well, it isn't the cost of the tablet. This is Merck. Merck produce praziquantel. This is them on their website telling us that they've just donated the 1.5 billionth tablet of praziquantel. They actually donate 100 million tablets. That's 500 milligrams, which treats about 12 kilograms worth of child. So you're looking at sort of 3 or 4 tablets per child. They donate 100 million tablets every year to the WHO to be distributed to these 78 countries that are endemic for schistosomiasis, and that's free. So that's not the issue. It actually gets more complicated than that, and I don't want to bore you too much, but on the left here is Sesol. This is praziquantel produced by Merck, donated. It's in a very big tubs because they donate large amounts for these MDA programs, and it's not registered with SAPRA. What is registered is cysticide. Cysticide is also praziquantel, and it's also made by Merck. Merck have 2 factories. One makes Sesol on the left, the other makes cysticide on the right. They are almost identical. They're slightly different weight, I think, but they're essentially identical. But one they sell to the government, and I'm grateful to, I think I see that Andy Gray is on the call, which is fantastic. And perhaps Andy can talk later about this because he's the expert. These are from slides that he gave to us. The state buys cysticide for about 18 rand a tablet, roughly in relatively small amounts. In the private sector, that's 31 rand a tablet. The issue is, to my understanding, is that the country is not able to accept a donation of an unregistered medication, Sesol, when there's a registered medication already available, even though the registered medication costs 18 rand a tablet and the unregistered one is free, and we have a public health emergency. Might it be possible under section 21? Well, actually, that's very difficult. Again, Andy might be able to come and just top up my knowledge on this, but essentially, SAPRA do not want to grant section 21 access to unregistered medications when there is a registered medication in the country, available in the country, even though these prices are so different. What are the other barriers? Well, again, this is from Andy Gray. Praziquantel is listed in Schedule 4 of the Medicines and Related Substances Act, which means it requires a prescription. And a prescriber to prescribe it to an individual. This is a real problem with MDA programs. In countries like Malawi, the teachers have kids and lots and lots of prescribers. The programs currently that's not. Clearly, there are other barriers. You know, if we got through these two barriers, we'd still have to set up a whole program. We'd have to get into the schools. We'd have to do messaging. We'd have to, you know, deal with the fact that some of these children would get side effects and other children wouldn't need to take the drugs. There are lots of other barriers, but I just wanted to focus on the main two at the moment. The main one being this inability for the country to access free drugs. So what might the solutions be? Well, one solution might be for Sessile to be registered with SAPRA. I believe that's difficult because that Merck have no incentive to do this. They would have to submit all their documentation and someone would have to pay the fee to SAPRA for this to become registered, and that seems to be something that is unlikely to happen. The alternative is for Merck to just donate the cysticide rather than the Sessile. Remember, it's essentially the same drug. Must cost them roughly the same to make, and so it should in theory be no skin off their nose whether they donate the cysticide or the Sessile. These two questions are both sitting with a group. So we formed a group, a Schistosomiasis stakeholders group, to try and get some tablets into mouths essentially, and it's a slow process, but both of these two questions are being asked at the moment actively. In terms of the Section 4, it is possible to apply to the Director General for a waiver of Section 4, such that the praziquantel could be handed out by school teachers. So it's 10 to 4. I'm going to leave it at that. I haven't seen everyone who's on the call. There may well be other people like Erin on the call. I know John Freehan is on the call. Lucille isn't. I know Andy Gray is. So I'll open it up for questions, and it might well be that one of the experts in the audience answers them. Thanks very much.
Great, thank you so much, Tom. That's an incredible overview and some fascinating and frustrating complexities at the end there. I wonder, Andy's got his hand up, so I think I want to give the floor to him next, just to maybe go through some of the issues with the registration and other issues. Andy?
Thanks very much. Thanks, Jeremy. And yeah, just a very quick input on the issue of donations. So there's an additional problem, which is, to whom does the donation go? Because of our single exit price, there can't be a discount in any prices to the private sector, and a donation is a 100% discount. The state is exempted from the SEP, so a donation to the state is possible. It's not legally impossible for SAPRA to issue a Section 21, but they are reluctant to do so when there is a registered product available. So the best bet is, as people have said already, to go directly to Merck and say, rather than send stock from elsewhere, can you arrange with your wholly owned subsidiary in South Africa to provide the state with cysticide, a 500 milligram tablet instead of a 600 milligram tablet? That's the easiest. For mass drug administration, it is possible to apply for a Section 22A15 permit for people who are identified to provide that narrow service. And it could be teachers, it could be community caregivers. There are different ways of doing it. The malaria program has done this with environmental health practitioners in elimination districts who are providing artemisinin combination therapy, even though it is prescription-only medicine. With the 22A15 permit, it's possible to get around that. So it's not an exemption from the schedule, but a specific permit tied to a training program and some reporting requirements. So that's the next step. But the big shift has to be the policy discussion within the National Department of Health, and then first prize would be to add that to the essential medicines list and to adjust the standard treatment guideline from just individual patient to including mass drug administration. And that's the process of providing a motivation and the necessary evidence for this country, and then a consideration of cost and feasibility. So those are in train at the moment. And one way we are trying to make that happen is to use funding that's gone to the Cochrane Center and the MRC for adaptation of international guidelines. And we are arguing that the schistosomiasis NDA guideline could be one that is a good option for that GELA project. Thanks.
Thanks, Andy. That's fascinating. And somehow frustrating too. But at least it does seem to be a way forward. I see that in the chat there's a lot of lively discussion about how to test for schistosomiasis, particularly at genital. So one question that did keep coming up, or at least a lot of people, maybe Tom, you want to speak to it, was about the genital schistosomiasis. So I think there's a lot of concern about it being underdiagnosed. So, who would you send for further testing for that specifically? And do you think it's a problem that needs more attention than it's currently getting?
I think undoubtedly. I see Erin has been writing in the chat. Is that if Erin is on the call, then we literally have the world expert on the call, I would suggest, and she would be perfect to answer. Erin, are you actually on the call, or are you just answering the chat?
Go for it, Erin. Yeah.
I think we open the floor to her.
Yes. So we don't have a system to diagnose female genital schistosomiasis yet, sort of a smooth run for that. PCR of a vaginal swab or a cervical swab on the lesion itself can be done, and AMPATH now just confirmed that they're doing schisto-PCR. And another possibility, or the best possibility, is really do visual inspection, but colposcopy is not available readily. So if you can teach yourself by looking at the WHO website, I put the link there for the WHO Pocket Atlas for female genital schistosomiasis, and use a really good light, then that's a possibility for a person who is well versed with gynae examinations. And the second thing is, obviously the gold standard is biopsy. You shouldn't take that blindly. You should take it targeted towards the lesions that you see. Anyone with stinking discharge, bloody discharge, where you suspect a sexually transmitted disease could as well be a genital schistosomiasis. And I see that somebody here has mentioned that you're seeing a lot of STIs in women who have not, in kids who have not yet started sexual intercourse, which is very much in line with what we found here in 1,000 young girls who have bloody discharge, burning sensation in their genitals, and this smelly discharge even before they have started sexual intercourse. So it is something that we should attack. You could go by, if you see that they have urinary schistosomiasis, problem solved. But if it's negative, you can't believe it.
Sure, that's fascinating. So, so go ahead, Tom.
Yeah, I would just say, I mean, the question is when to give empiric therapy, or when is your threshold at the level that you would treat. And as I would say, these drugs are available, and they have very low side effect profile. So you can chase a diagnosis with if you have the skills, but you're not treating with cancer chemotherapy here. You're treating with a single dose of well-tolerated medication. And I mean, one interesting question would be, how quickly would you expect, if you use a trial of treatment, how quickly you'd expect the symptoms to settle? And that would be an interesting thing. If we knew that, if maybe Erin knows that, then that would help us with knowing whether we were on the right track.
So the effective treatment is very slow, and I think one of our tasks is really to inform women that we've now treated you for a sexually transmitted disease 3 times, and we're trying praziquantel, and it will take months before this is resolved. And it looks like the lesions may remain for a long time, but the symptoms of the lesion seem to diminish a little bit with time. So yes, that's what I can say about that. One of our important tasks in meeting our patients is really to inform them that this isn't a sexually transmitted disease. They no longer have to pick a fight with their husband about it.
And Erin, if I may ask, so is it still just a stat dose for the genitourinary schistosomiasis of praziquantel?
Well, yes and no. It's the same as for urinary schistosomiasis, but we see that only about 80% of the people who have who get treated, urinary or not urinary schistosomiasis, they 80% of the worms get killed, but some of the worms are still alive after treatment. And some people require 2 doses. And obviously, if you're in continuous contact with water, risk water, then you will be reinfected immediately again as you go in. And it seems like the worm goes back to the same. It has predilection sites inside our bodies, and if it's found that it's a good spot to be in for one worm, then the next worm comes and sits there in the same region and creates the same, spews eggs to the same area that you have already have a problem in. So personally, it looks like there's a lot of literature coming out on this now, that we would treat them twice with 6 weeks between but it's a stat dose and then another dose 6 weeks ahead, and you could go high up in dose as well. We usually say 40 milligrams per kilogram, but you could go up to 60 milligrams per kilogram as well.
Thank you. That's really, really fascinating. I mean, is it presumably this is the eggs itself that's eliciting the inflammatory response? So is it a disease really of bulk? In other words, would you expect to find this outside endemic regions? I mean, someone who goes, let's say, arguably to Lake Malawi gets swims there, gets a burden of acute schistosomiasis, but presumably not enough worms still to give the chronic complications, or is that not true?
That's not true. And in fact, the disease is cumulative. So the worm can live in our bodies for about 30 years and they excrete eggs throughout the time. We've seen expat cases of people who deny having been back to endemic areas who are still excreting live eggs after 30 years. Obviously, those are the exceptions. The mean age of a worm is around 5 years, they say, but nobody really knows. But so the eggs, they can be fresh eggs, and the longer you have a worm, the more eggs will be deposited in your tissues. So you could say that delaying treatment after a visit to Lake Malawi, and you say, okay, I'm just going to see whether this progresses or not, is the wrong tactic to do. You actually want to be quite aggressive with it and try to get it as early as possible. And that's why we want to insist that children get this really early. We think that they get it already as infants. And by the time they get there, immediately when they sit in the bucket next to grandmother and she's doing laundry, and many of the children that we interviewed, they denied having had any water contact. Either they lied to us because they thought we would shout at them for swimming in the river, or else they just didn't remember because this had happened when they were infants. So 20% of the ones that said, I've never touched the river, never touched a water body, 20% of those had schisto eggs in urine as 10 to 12-year-olds. So, and this was girls only.
Well, that is a fantastic talk, Tom, and thank you very much for those of you who chipped in as well. Erin and others in the chat. There's a very lively chat and going on as well, backwards and forwards with lots of good ideas. Tom, thank you so much. I've learned a lot, and thanks to Erin and others who contributed to, and Andy for explaining some of the legal and regulatory pathways forward. And I wish you well. You're going to be talking on this topic at the FIDSA conference later in the year, Tom. So we'll look forward to see if there's any updates on any of that from there. But thank you so much. It's been incredible. Thank you.
Sure. Thank you.